Perfect. So I'm going to go ahead and mute everybody so we all have our respect and we can hear the physician speaking. So good evening. My name is Tracy Milgram Posner. I'm the founder of BRCA Strong. BRCA Strong is the local nonprofit to educate, support, empower, and advocate providers, survivors, and thrivers to eliminate the feeling of isolation and help you feel whole again. We fund women post-mastectomy garments and lymphedema sleeves. During COVID-19, we have gone ahead and shipped out several baskets and books to women who are starting treatments or just going in for surgeries during this time. If there's anybody that you know that's out there that we can help support them through this time, please go ahead and share that information with them to reach us at BRCA Strong, and we will do anything to help them get through their journeys. I'm going to go ahead and pass the mic over to Dr. Negron, as I'm so excited for both of our physicians today to join us, as this topic is so important to me and imperative to reach our community so everybody is aware of knowing your options, as I'm a true believer is knowledge is power. Thank you so much, everybody, for joining, and I look forward to this talk tonight.
Hello.
Welcome.
Hello. Hello, I'm Dr. Martir-Negron. I am a medical geneticist and my specialty is oncogenetics. And I'm a physician, I'm the geneticist in MCI. And I want to tell that, you know, we're doing telehealth, but MCI is really doing a lot to try to get for the patient safe. So we physicians and the employees, we get screened, and every patient coming in gets screened, and if there's any symptoms, they get tested. And if they get tested, they don't go back to the building. They are drove to their car, and then they're called for test results. So telehealth is a way that we can reach patients, but we are seeing patients in person too. And we're changing the building, the way the people, the waiting area is also changing to serve our population. This is basically where I do the telehealth, and my clinic is in the past 2 months, a month and a half, I'm being telehealth. Genetics, I think that works very well with telehealth. The issues before were that the insurance were not paying for the visit. And if the patient wanted telehealth, they have to pay for it. And it was, in some cases, expensive, or the technology wasn't available. Now with the changes in regulation and CMS allowing for telehealth, that has opened the door that I think that it will be very difficult to close for the use of this technology. There is not much different what I will be doing with the patient in terms of the talking when we do telehealth. Now, if there is a genetic defect that is associated with physical features, then a clinical examination will be recommended. Or for example, when somebody comes to see me and they have been referred for a condition that is associated with physical features, if I have to do telehealth, I have to mention that that part cannot be completed, and eventually when we get together again, or then we can plan to see the patient in the hospital. But in the majority of cases, there is no issues. Another good thing is that the laboratories has they're validated. The saliva kit is validated. So this is all the labs use this same kit, and this is, I have here props for the patients when I'm talking to them. I show the panels, and I mention that they will receive this. So this is the kit when you get saliva. So what are the pros and cons? So the pros is that you don't have to come and be exposed, especially the majority of our patients they already have cancer, so they're immunosuppressed, or they're doing chemotherapy. But I prefer blood because DNA is readily available. So the pros is that that you can receive this in your home, get the collection. I'm going to explain more about the collection. You call FedEx, go pick up the box, and there have been no delay in terms of test results. The tests are resulted in the same amount of time than before. The cons is that sometimes the patient do not collect this well. So let me talk about the collection part. So this is, it's not a swab. You have to spit. And but the situation is that, and I always show to my patients, let me see if I can find a pen. I don't have a pen now. But this is empty. So this is a waste of plastic here. The saliva sample is only from here to there, where the line is. So it's not a lot of saliva, but you spit in there, and you have to collect just saliva until that top, and they could be bubbles, but it has to be in top of the line. Because if they're not in top of the line, there is insufficient sample. Then the patient has to close this. There is a little plastic membrane here. I don't know if you see the liquid. And when they close, fluid goes there. They have to remove the cap, and they have to close it. So this is the collection. The problem is that the collection has to, you cannot drink, eat, or chew anything 30 minutes before. So what, and the problem is that sometimes they get DNA, and it's DNA from whatever they ate. So they have found bovine DNA. Obviously, that is one of the issues that we have. So one of the cons is that the sample, the issue with the collection, if there is not enough collection. The problem is, and sometimes it's not a big problem with somebody with a history of cancer, but it is somebody who's making surgical decisions. Doing the saliva may delay, and this is something that we explain to the patient. It's rare when they said that the sample failed, but we have cases. In terms of the quality of the test, there is no issues because they are looking for the DNA and there's cells in the saliva. Who cannot be tested with this? So it will be people, for example, that are not for the breast, it's more for, and I'm gonna go into a lot of details unless there is a question. We have for patients with colon cancer, a subset of patients of colon cancer and uterine cancer, we need to send sample that is the blood with the tumor, and it's not validated for saliva. Something else that is not validated for saliva is there are new, labs are offering DNA and RNA. RNA is like a step ahead. So the purpose of the gene is to have the recipe to make a protein. And what the, but it's not, there are many steps. So that is way simplified. So it's DNA goes to RNA. So when you do RNA, the idea is for some of these inconclusive, and I don't know if you're familiar, so when we do genetic testing, there is 3 possible results: positive, negative, and inconclusive. So when we found an inconclusive, it takes time for the lab to gather more information. And it's just a change that we don't know. Remember, the purpose of the gene is to make a protein. We don't know if that change is expected to cause problems in the protein. I said to the patient, this is negative until proven otherwise, because in 90% of the cases, it's nothing. So the idea of the RNA is to try to help in the interpretation. So depending where the mutation is, it's possible that this other step that is usually offered for free in some labs will give us an answer. But that is not clinically validated, but it's not something, it's not clinic, it's not, I'm sorry, it's clinically validated, but it's not validated for saliva. So that is one issue. The other issue is if somebody has a bone marrow transplant or somebody has leukemia, or has history of leukemia, but it hasn't been more than 10 years. And we look at the type of leukemia. Not all the leukemias, the patients are not candidate for saliva, for saliva or blood. But in reality, if you have had leukemia or you have bone marrow transplant, you are not even candidate for blood samples. So for those patients, those are the type of patients we have to tell them that we need to do a skin biopsy. So a skin biopsy is a very, it's like the top of a, you know, the click of a pencil, and it's just a little, just like this, just the top of the clip of the pencil of skin, and that is sent to the lab, and they have to grow the skin cells, and they get the DNA from there. So it's just a few patients, but this is important because first, we cannot do it, we can have the discussion, but the sample collection has to be the biopsy, and that has to be planned. It's not many patients, but it's very important, and it also takes approximately 8 weeks to have results. But for the great majority of patients, we can do this part in telehealth. Regarding the results, we see the patient, we give results. If the patient is positive, we discuss in detail, and we do make the referrals. I refer to Dr. Diaz a lot, but we refer to also if the patient haven't seen a breast, has not seen the breast surgeon because his family history and they're unaffected, we send the patient to see the doctor. Obviously, and in that case, I want to mention something that is not usually mentioned. If somebody like a family, one of your family members that is unaffected, meaning they haven't had cancer, want to have genetic testing, it's important that they get life insurance, disability insurance, and long-term insurance, because there is no protection for that, and is extremely important. If there is any physical examination that is needed, we just plan for, I'm seeing patients in person now Mondays and Thursday, and we're expecting to be able to see, to open more days of in-person clinic, but we plan for that. If there is, it hasn't been any delay in this process in which what happening delay, we are doing very well because we are seeing all these patients that were in the waiting list. So we are doing well because we're seeing many patients, and we're seeing all those patients making surgical decisions, and they have the test results, usually with a lot of time before the surgery is scheduled.
Perfect.
Okay.
You know, I do have one question, just as I know we have a couple new people. Maybe you can just do like a basic definition of like, what is hereditary testing? Not like even just BRCA, but like what the, you know, like explain a little bit maybe about like what hereditary testing is, just to the community who doesn't know.
Sure, but first, the majority of cancer is, well, all cancer is genetic. So basically a change in a cell, and it went crazy and grows and become cancer. That is in all cancers, but as a group of a percentage, we are saying now that is approximately 15% in general for all cancers, and for ovarian cancer is 20%. Of the patients carry a predisposition. That means that they, without knowing, they were born with a defect that put them in an increased risk for developing cancer. So usually the cancer occurs earlier because because you were born already with a defect, so it's easier for you to develop cancer. Usually cancer that is associated, we call it multifactorial. meaning that it's not because of a predisposition, happened later. The being born with a predisposition doesn't mean that you will develop cancer. Means that you are in an increased risk with that of the general population. We all, by being alive, humans, and let's say, I haven't had genetic testing, never, because I don't meet criteria, but like with a family history, my risk of developing breast cancer is approximately 12.5%. But in some cases, if you're depending on the mutation, the risk could be up to 70%. The 85% that they were saying in BRCA, new studies demonstrate that it's lower than that, so it's approximately 75%, but there are also other genes that the risk is 30%. So people with predisposition, the risk for breast cancer can be between 30 to 50%. In the case of ovarian cancer, it could be between 6 to 47%. So that is increased from 1.3% general population. And with this information, with the knowledge that you carry a mutation, you can do a lot to prevent. You can, and I always tell my patients, some of the decisions that you have to make is not easy. They're not easy, but when you put it in a balance and you think about your well-being, your life, these are the right decisions. What we're looking is for defect genes, and this group of genes in majority are tumor suppressor genes. That means that these are good genes that what they do is protect you against cancer. So when depending on what they do, they have different functions in the body that when they see that there is a defect, they can correct and cancer doesn't happen. So never these genes, so the correct way to say is I carry the scientific way to say it is I carry a pathogenic variant, because all the changes that we see are mutations of pathogenic variant. Or you can say mutation because it's commonly the way that we say it. It's not I have the gene, because we have these genes. When somebody has a defect, is that what they have, a defect. The gene is not working as supposed to. These genes are never bad. They are not doing the job, and then cancer may happen. And it can be passed through mom or dad, even though it's difficult to see that an ovarian cancer risk can be passed through father, but it's because 50% of our genetic information comes from mom and 50% come from dad. We have 2 copies of each gene, and a mutation can be passed either from dad or mom. What happened is, in some cases that a mutation comes from the paternal lineage, is that we don't see breast and ovarian cancer as common like in BRCA, because the probability of a man to develop breast cancer is only 7%, and I said the risk for a woman is 70-something%, and they don't have ovaries, so they will never develop ovarian cancer. Therefore, it just gives you an idea that it kind of jump generations, but that is not the case. There is a 50% chance in the majority of these genes to predispose to cancer. For some of the genes, carrying 2 mutations makes it worse, or it can be associated to in some cases, fatal or diseases that can cause a lot of problems in childhood. But the majority of these cancer predisposition syndrome are carrying one mutation, put you in an increased risk for cancer. Again, increased risk, that doesn't mean that you will develop cancer.
Perfect. Thank you so much for explaining that. So what I'm going to do is I will pass the mic over to Dr. Diaz, and then when Dr. Diaz is done, we'll open up a Q&A. So if anybody has any questions, you guys have a couple of minutes to go through that and then be ready for Dr. Diaz. All right. Let's see.
Hi, Tracy.
Welcome.
Thanks again for having me, and thanks again for organizing this.
No problem. Appreciate your time. And I know you're busy. You guys are busy seeing patients all day and then doing education at night. We're super appreciative and grateful.
No worries. So that brings in one of the first things I want to talk about, which is, we are open for business. We're seeing patients. both in person and via telemedicine. And after about a month of really slowing things down, we're back to a regular flow. It's a little bit different than how we did things before. And patients have had a little bit of a concern about going to an institution for this. And we are the largest cancer center in the state of Florida, 500,000 square feet, but we're also a separate building from Baptist Hospital. So all of the employees coming in every morning are screened for COVID, their temperatures are taken, as well as an extensive questionnaire, and the same thing for our patients. We've kind of remodeled the waiting room to allow for 6 feet between patients. All of our patients are given a mask, although honestly, many are already coming with their own masks. And we're really practicing best practice we can. We recognize in our health system that the patients that are coming to our center are those at the highest risk of having a complication should they acquire the COVID infection. And having said that, we just got off a meeting before this. We've only had 22 patients and or providers at all of MCI who have actually tested positive for COVID, which is really a small number. I was kind of surprised by that, especially because I had 2 of those patients. So what are the chances? So really, we've done a really good job at screening and making sure that those patients who are at risk or showing symptoms are not admitted into the building, and to make it a safe environment for our patients. The other thing we've done is really transition to a lot of telemedicine visits. And I think that's been great. I wish we could do more of this. And again, it's a matter of insurance, as we've talked about. Hopefully, as Arelis alluded to, now that the genie's out of the bottle, insurance companies will recognize the value of this and allow us to continue to provide these services for our patients. One of the challenging things has been, especially in the first month, was how do we continue to treat patients with cancers, especially those that we normally treat with surgery, when at that time we wanted to really preserve the machines we use in the operating room, such as ventilators for ICUs. We wanted to avoid blood transfusion and certainly wanted to avoid any big surgeries that required ICU admissions. So in the initial periods, we had to kind of change our strategies. Patients with endometrial cancer, for example, were initially treated with hormone therapy to kind of bridge it until we had a time for surgery. Patients with ovarian cancer, as you know, the surgical management for that is a big surgery. So we started most of those with chemotherapy. And now we're kind of getting to that point where we have to start just talking about going to the operating room for surgery. So we've had to change our practice a little bit. But this week, we're first week of going up and running. I did 10 cases this week already, trying to catch up with our backlog. We've continued to give chemotherapy in the settings, although again, we've had to rethink kind of where we are. Obviously, a patient with a new diagnosis, we want to make sure that they get treated and there are no delays. In those patients who maybe have had a recurrence of their disease and have seen multiple lines of chemotherapy, we've had to see, okay, is it really in their best interest at this time to continue to receive palliative chemotherapy, or is there another way to treat these patients and reduce the risk of being exposed? So it's been some challenging, not just for us, but for oncologists all around the country and the world. And I think this is going to be with us longer than I think any of us expected. So we're again back to open, we're seeing patients, and we're back to treating patients the way we have always treated patients. There are some challenges again with limiting visitors. So a lot of times patients are having to come to these visits by themselves, which obviously can be challenging when talking about a cancer diagnosis or going through your treatments. We do make exceptions for those patients who have some kind of cognitive or physical impairments. But again, we're doing this to try and limit the exposure to the patients and the providers. So that's what I want to kind of get up. We're back up and running. I know a lot of people also concerned about screening, right? I was due for my mammogram, but all of the radiology centers have been closed for the last 2 months, or colonoscopies and things like that. So that's why it's really important to be up to date. So if you've had a delay in your mammogram a couple months, it's probably not that big a deal. But if you haven't had your mammogram for 3 years and this was you're going to get it done, and now things have been delayed, obviously that's more challenging. But our centers are back up slowly to running, so we should be able to get everyone in for all of their screening programs. Procedures are a little more difficult. Colonoscopies and things like that have been a little bit slower to get back on track, but we are starting to do that again and kind of trying to triage patients. And then things like pap smears and all that we're still doing. So happy to answer any questions anybody has specific about what we're doing for our cancer patients or GYN oncology or anything you guys can think of But it's nice to get back to doing what we all love to do.
Perfect. One question I know that a lot of women had was, I don't know if you want me to open up for a Q&A or maybe talk about the use of hormones with either survivors or survivors. I know a lot of women had several questions on that. I don't know if maybe you just want to start with like a general discussion and then go from there.
So when it comes to hormones, hormones are important for women, right? Particularly estrogen. So we know that the #1 killer of women in the United States is not breast cancer, it's not ovarian cancer or lung cancer, it's heart disease. And one of the things we know that helps protect women's hearts is, besides genetics, is estrogen. And estrogen helps protect your hearts. The average age of menopause in the United States is about 51.3 years. And once you go into menopause, you decrease your estrogen levels, but you don't eliminate them altogether. And so some of the questions we have are for those patients who are deemed at increased risk of developing ovarian cancer. Oftentimes, one of the things we discuss are risk-reducing strategies, including things like risk-reducing surgery, such as removing the ovaries before menopause. Usually, we want to do this about 10 years before your risk for developing an ovarian cancer. So when you do that, you eliminate that estrogen. And so women are put into menopause sometimes 10, sometimes 15 years before they're supposed to. And so you have that impact on your heart, on your bones, and just your general well-being. So we like to, at least our practice has been in those women, unless they have other contraindications, to put them with some kind of estrogen replacement therapy. Again, it's good for their heart, it's good for their bones, and just their general well-being. In those women who have a history of breast cancer, it becomes a little bit more challenging. Breast cancers, many of them are estrogen receptor positive. And so the concern is, if you're giving a woman who has an estrogen receptor cancer or had a history of that, and you're giving them estrogen, are you increasing the risk of having that cancer come back? In the GYN world, we did a study that looking at endometrial cancer, which is also an estrogen-driven tumor. And what we found in that study was, in fact, those women with endometrial cancer who received estrogen therapy did not have an increased risk of that endometrial cancer coming back. We don't have those studies in breast cancer, and it makes it a little bit more challenging, especially because many of these women are on anti-estrogen therapy. So that becomes a little bit harder. It's a conversation between not only gynecologists, but also their medical oncologists. And it really becomes a balance between, okay, what is their risk? What stage were they with their breast cancer? Are they ERPR positive and receiving this estrogen to having this cancer come back against? What are some of their quality of life issues? Not just cardiac health, but are these women really symptomatic with hot flashes or dyspareunia, difficulty with relationships, or things like that? And the postmenopausal situation becomes even more challenging. For a while there, women really sought out for hormone replacement therapy. It's kind of tapered off, but I see it making a comeback now, not just with estrogen, but testosterone and things like that. So it's really a challenging scenario, and it depends on a lot of factors for the women. And then the one thing is, what is our goal with this? Is it cardiac health? Is it generalized quality of life? So it's an important thing to talk about with your GYN.
Perfect. Thank you so much. What I'm going to do is I'm going to unmute everybody, and then slowly, or if you guys want to raise your hand, we could do it that way. Unmute all. And you guys can go ahead one at a time if you want. Or, I'm going to mute everybody, and then it's going to be easier. Go ahead. Aaliyah, you want to go ahead and start?
Yeah. Thank you, too, for coming on. This is very informative. So I want to make sure I say this correct, because Dr. Arelis said it is pathogenic. Was it mutation? No, it was pathogenic, something like that. I don't want to say I have the BRCA mutation anymore.
It's variant, pathogenic variant.
Pathogenic variant. I am now corrected. Thank you, because now I feel like one of the Avengers when I say I have the BRCA mutation. Thank you. Okay, so here's my question. I learned that I was BRCA2 positive in February of 2019. And this is to both doctors, okay? My daughters now are 29 24, and 20. At what point do I suggest, or do I've already had a conversation with them about getting tested? My mom has not been tested. I do have the breast cancer history on both sides, my mother's side and my father's side, right? So I would be the one that knows for sure that I carry that particular variant. At what point do my daughters talk to their gynecologist about being BRCA tested or BRCA tested?
So the medical care changed at the age of 25 for them, in which you will recommend MRI. So it's breast MRI from age 25 to age 29. And then at age 30, it changed to both MRI and mammogram alternates every 6 months. That is always my recommendation. There is a recommendation for BRCA2 to be screened for melanoma, and that is something that everybody in South Florida should do because, you know, where we are. So that the main issue will be the screening, because it will be what it will change, and it will require insurance to pay something expensive. You cannot go and say, I want an MRI because I may carry a mutation. In my experience, the closer to age 25 that you do this, the genetic testing, the better. I have the experience of having a mother. She brought an 18-year-old. She just finished high school, and it was in August. So she was going away for college. And I mentioned she had a 50% chance father carrying mutation, and I said, you know, it's not necessary. She's now going to college, so many experience. She needs also the maturity that you can get. And it was no need to do genetic testing earlier, because we always look at the ages, and the youngest cancer in the family was a breast cancer, was a 40. So there was no need. And then, so I mentioned we're gonna do the testing, and the plan was when she came for Thanksgiving, she will come and we gonna give the results. And we did that. She was positive. And when I told her, she just ran out of the office, and I was talking with mother, because it was too much for her, because she wasn't ready, and she was 18. So not every 18 is the same, but I really believe that there is no point of doing this genetic testing, especially if we don't have to move the screening earlier. There is need for maturity. There is need for just spend your time. If you go to college, just do what you need to do. Another reason that somebody will do genetic testing early will be because I say maybe the only other reason is you want to have children, which I don't recommend younger than 25. But if you want to have children and then you want to do pre-implantation genetics, well, you need to know. And I don't know if you know what is pre-implantation genetics. Basically is, again, this is not for everybody. So when I always have to explain that, because some people, they don't find this right. But pre-implantation genetics is basically, you know, that you carry a mutation, and it has to be done in vitro. So in vitro, they remove a cell from the embryo, and they only transfer the embryos without the mutation. And that is a way that you can know that your child will not carry a mutation. So, but it's expensive, and it's not for everybody. But that is maybe the only way, the other way. When it's a man, I say to a man, either if you do pre-implantation genetics, it is something for you to do it early, but really a man can wait. They can wait until age 40, the reality. But I said, you know, 30, because the screening, the breast screening, which is only a clinical exam. So a man may decide, I don't want to have genetic testing, and it's easy, because it will not be something that has to be approved for the doctor to do a clinical breast exam. But this is doing genetic testing. Definitely, I'm against genetic testing in children. So younger than 18, I'm not recommending. It's not recommended by any of the big, the American College of Medical Genetics, the American the American Society of Human Genetics. So all these are against it, and but it varies from people to people. But I really believe that it shouldn't be done before 25, also, or close to 25. Also, like I mentioned before, there are protection in law for health care. You know, the GINA, Genetic Information No Discrimination Act, it was signed into law in 2008, so it predates Obamacare. And so I said that because some people are afraid what happened if the Obamacare goes away. It was before Obamacare, and it protects you. There are some details, so you have to be, they mentioned the size of the company, but many of these things, together with Obamacare, there are a lot of protection for healthcare, but there is no protection for life insurance, health insurance, and disability. So it have been very difficult to discuss with a 22, 23, even 25-year-old, 26. You should get life insurance because they don't see that, you know. Life insurance becomes important when you have children. When you don't have children, well, it's not that important. And that is something that they need to do because they may be discriminated, and the law hasn't changed. You know, I'm working in a presentation for ethics, and I have been reading a lot about laws in genetics, and they have not changed. It continues to be that there is no protection for life, healthcare, and long care.
Thank you.
You're welcome.
From a GYN standpoint, you know, they're at increased risk of developing ovarian cancer. With BRCA2, it happens later in life. We do recommend starting some kind of ovarian cancer screening at about 30 or 35, and that usually entails undergoing a pelvic ultrasound and looking at a tumor marker that's called CA125. And we do that every 6 months. We do it because it's the best thing we have. Unfortunately, no, it really doesn't work. It doesn't catch ovarian cancer early. There's some research showing that if you look at the pattern over time at that CA125, that may be more meaningful than the one-time evaluation. So again, we start at about 30 to 35 years of age, but really, especially with BRCA2, probably by 45, we need to start talking about a risk-reducing surgery. And again, the idea here is to do surgery before you develop an ovarian cancer to remove the ovaries and also the fallopian tubes. One of the things we also recommend, or at least discuss with our patients, is using birth control pills. So women who use birth control pills for more than 5 years decrease their risk of developing ovarian cancer by 50%. You know, there's some data out there that says there may be an increased risk in breast cancer. There's just some data that says that there isn't. But at least with breast cancer, we do have effective screening. With ovarian cancer, we do not. So we do recommend those women who aren't ready yet to do something surgical, and if they're not at the point of seeking fertility, to begin birth control pills. And then again, about age 30, 35, start with their screening, knowing that ultimately, though, our recommendation would be for risk-reducing surgery later on, but before their risk of developing ovarian cancer increases.
And something else I want to mention, it's very important that ideally to go to a genetics provider, because the issue is that if you go to maybe your gynecologist, they may also only test for that particular mutation that is in your family, but we are looking only at that side of the family, the maternal lineage. We have to look also for the father side. So I have recently a case in that there was a BRCA2 mutation, but when we did coming from mother, but when I look at the family history, I said, well, there is a pancreatic cancer. We should do a panel. And in this particular family, mother carry a BRCA2 mutation and father carry a BRCA1 mutation. So the one daughter has the BRCA2 mutation and the other the BRCA1. So we need to look, and if there is colon cancer, there are other genes that we need to test, not only that single gene. Now, if there is nothing else in the family, if the family history is not suspicious, yeah, we can send for the single side, but it's something to be aware.
Okay.
Any other question?
I know, I was
Sorry.
waiting for Tracy to come back.
Yeah, where's Stacy?
I totally lost you guys. One other question that we had was, is there any screenings for prostate or pancreatic cancers?
No, that's a great question. So for prostate cancer, yes, there is I said the PSA and I mentioned the digital examination, and the patient said, "Oh my God, there is new imaging," and I said, "No, is that the finger test?" And there is the possibility, and this is I went to. I went to Chicago in a meeting like this a couple of weeks ago, and they were discussing that there is imaging coming up for patients who are in an increased risk for prostate cancer based on a mutation. But also something very important is that threshold for PSA is lower when somebody carries a mutation. So whereas somebody without the mutation, the doctor will just observe. If the PSA is a little bit elevated, they will be more aggressive in trying to find if there is cancer. In terms of pancreatic, a lot changed since December, I think that December 19, 2019, so very recently. We knew that there was a group of experts that created guidelines, but it wasn't paid by insurance because it was a guideline from a community of experts. It wasn't in the National Comprehensive Cancer Network guidelines. And now we finally have guidelines for pancreatic cancer, but the screening is not for everybody who carries a mutation. And BRCA2 is the one with the highest risk, although it's low, the risk is 7%. And there is also an increased risk in BRCA1, but it's not as clear. But there are other genes associated with increased risk for pancreatic cancer. There is one that the risk could be up to 58.